today I'm going to talk a little bit about the research that I do and have done, and now it's called translational research, which is fairly new, that term anyway. Before we called it intervention research, but it's really become translational now. And then talk about dissemination and implementation research that we also do, which kind of comes out of evidence-based practices. So as I mentioned, in New Mexico, some of the first question, that really drove me down this path in diabetes is, why do American Indians suffer a disproportionate burden of diabetes and diabetes-related complications? And why aren't they benefiting from what we know? So we know that they do these, NIH does these large clinical trials across the country, and they come up with these evidence-based practices. And so translational research was introduced as part of the NIH roadmap in about 2003. So translational research is a systematic effort to apply discoveries generated during research in the laboratory and in preclinical studies to the development of trials and studies in humans. In our work, our research is aimed at enhancing the adoption of best practices in communities. Cost effectiveness of prevention and treatment strategies is also an important part of translational science. Also in our work, our researchers partner with communities and ask for ideas about how their findings might apply there. Together, they would come up with an intervention plan that would also include scientific evaluation of its effectiveness. So we work together to come up with the plan, a culturally appropriate, tailored plan that is acceptable for their community. So this is just a graphic of the continuum of clinical and translational science. So you see at the very top, the T0 is, when they're doing the laboratory sort of work, you're looking at biomarkers, genes, pathways, and then you move to T1 research, which is like first in human studies, the phase 1 and 2 clinical trials, proof of concept trials, and then you move to T2, which is the phase 3 trials, clinical efficacy, coming up with clinical guidelines. The T3 then is dissemination of evidence-based practices or these clinical guidelines, community engagement, health services research, comparative effectiveness. So ours is more T3 and T4. And T4 is the public health, prevention, population health impact, and then T5 are the social health care and moving way upstream to change policies and things like that. So dissemination, we do dissemination typically after there are evidence-based guidelines or practices that have been tested in efficacy trials, and then dissemination after our interventions have been completed. So dissemination is the targeted distribution of information and intervention materials to specific public health or clinical practice audiences. So, some people do trials with providers, and so they'll, our director's big on creating toolboxes for providers. So, if something like that is helpful for providers for something, then we'll create this toolbox and get that out, distribute it to providers. So the intent of dissemination is to spread knowledge about evidence-based interventions. Some of the common channels of dissemination occur through the internet, trainings, newspapers, journal publications, and presentations at conferences. So for us, it's typically, presentations and journal articles and things like that. And dissemination research then tries to figure out the most effective ways to create, package, transmit, and communicate information about evidence-based information about among a variety of stakeholder groups. Then implementation then is the process of putting to use or integrating these evidence-based interventions or practices or guidelines within a setting. We try to understand the behavior of the people implementing it. So might be decision makers, could be people within a community, and then within the context, so within the real world. So, you know, the T1, T2 trials that happen in labs and in strict like clinical trials, that's really not considered the real world. The real world then is taking what you learn in the lab or in these rigorous clinical trials across the country, and then putting them into real world settings like tribal communities or African American communities or something like that, where, as we know, a lot of racial ethnic groups aren't included in clinical trials for many different reasons. So we don't even know if they're going to work for them. And we found out, you know, even in drug trials, they don't work, drugs don't always work the same for racial ethnic groups that they do for the people that were in the study, which is typically white people. So why are translational dissemination and implementation research important? Translational research was designed for the medical world. It emerged in response to concern over the long lag time between scientific discoveries and changes in treatment, practices, health policies that incorporate these new discoveries. So this is astounding. It takes an average of 17 years to implement new clinical research findings into practice. And so that's why there's now a big push for translational research by NIH, because it takes so long. So while there have been tremendous advances in medical care, we know that there are efficacious and effective programs, drugs and treatments that aren't being implemented or not implemented yet. So a couple of examples illustrating this delay from discovery to implementation are penicillin and smallpox vaccine. So Fleming discovered penicillin in 1928, but the use of penicillin wasn't implemented for more than 15 years later. The smallpox epidemic raged in Boston in 1690 and 1702. The Jenner vaccine was developed in 1798, but then the last natural case occurred in Somalia in 1977. So it's a really, really long time to finally eradicate something that we had a vaccine for. So imagine the health and quality of life of people and lives saved if we were able to implement what we already know in less time. So this lag from discovery to widespread implementation in public health is a key reason why D&I, dissemination and implementation research, is needed, because it could help us figure out how to speed up the process. So the example that I want to share with you then is that of type 2 diabetes. And I kind of my career got started in type 2 diabetes and self-management and creating culturally tailored programs for American Indian communities to improve self-management of type 2 diabetes. So it's a fairly well understood pathophysiology that chronic hyperglycemia, that's high blood sugar, can cause severe end organ damage. And they found these, they established this research in that T0 to T1 studies, which led to then research resulted in multiple medications. So we have lots of medications for type 2 diabetes now that control high blood sugar or hyperglycemia, along with, of course, we know now weight loss, and maintaining a healthy weight and exercise is helpful too for people with diabetes to control high blood sugar. Yet we know these things, but there are huge disparities in type 2 diabetes between whites and racial ethnic groups. So why is that? And what can we do about it? Where's my eagle? There he is. So my first project in New Mexico was called Strong in Body and Spirit. So the woman I worked with there had gotten a grant from NIH, and the institute that we typically, that I get a lot of funding from is called the National Institute of Diabetes, Digestive and Kidney Diseases. So they focus on diabetes. And so this was we called it Strong in Body and Spirit, and it was with Pueblo communities in New Mexico, and it was designed to assess the effects of a culturally appropriate lifestyle intervention on A1C among Native American adults with type 2 diabetes. So A1C is it's a blood test, and it's a measure, it's an average of your past 3 months of blood sugar. So now they have point of care where it's just a finger stick, and you put it in this machine on a cartridge, and it can tell you what your A1C is. So normal A1C is 6 or below, and when you have diabetes, it's going to be above, well, the goal is below 7, so it's a percent. So the goal is below 7%. But we see people with like 10, 14, and that's really, really bad, because diabetes can lead, high blood sugar then can lead to really bad things like blindness, amputations, neuropathy, where you lose feeling in your fingers and toes, and kidney disease and dialysis. And then most people with diabetes die from heart disease, although most people die from heart disease anyway. But it's a difficult thing to manage. So it was an educational curriculum, and most of the things I do are curriculum based. The curriculum focused on improving dietary and physical activity behaviors. The study was 1993 to 97. It was in 8 New Mexico Rio Grande Pueblo communities, and divided into 3 geographic sites, and it was delivered by trained community health workers or community members. It was quasi-experimental. We didn't do a randomized trial for this one, and that's something you have to consider when working in communities. What methods are you going to use? Because a lot of times, if you haven't ever worked in that community before, they're not going to want to do a randomized trial where some people are going to get the program and other people aren't, because to them, that's not fair. And why are you doing that? Why would you withhold something that's potentially helpful from some people and then give it to other people? So in this case, we did a quasi-experimental. So just, pre-post test is quasi-experimental. There are other ways, to do things with communities to get a randomized control trial. So I typically now do a waitlist control group. So you still randomize people, and everybody's going to get the program except your waitlist group is going to get it later. So they're your control group, but they're going to get the program eventually. And for budget reasons too, that's more effective. So we did have improvement in A1C among the participants of Strong in Body and Spirit. And afterward, we were lucky enough, after the research project was over, we were lucky enough to get funding from the American Diabetes Association and Bristol Myers Squibb Foundation. So drug companies often have a foundation arm, and you can get money from them to do things, to develop a train the trainer program. So we developed another curriculum for the training, which, very practical. And we had a nurse that worked with us, and she was very practical. And so we went through the who, what, when, where, and how, because interventions are hard to do. And when you're going to train somebody to do that, usually, there's a manual of procedures or a protocol training. And so we wanted to develop, it's kind of a cookbook, right? A recipe book. So you have to, and if you've taken technical writing before, it comes in super handy. It's like writing instructions or writing out a recipe. What do you have to tell somebody so that they can replicate this in their community? They can just pick up this book and go do it in their community. So if you ever get a chance to take technical writing, do that, because it's really helpful. And I'm sure you've all seen directions on things or instructions that you've purchased, and maybe it's made in China or somewhere, and English isn't their first language, and they write these instructions, and you're like, that is so weird. That doesn't make sense. So we developed a Train the Trainer manual, And we did 4 regional trainings across the country with 39 teams and 159 individuals from tribal communities. So we advertised it in communities, and it was a free training and because the ADA and Bristol-Myers Squibb sponsored their travel. And after the training, it was a week-long training. After the training, we called the teams up. We had them identify one person in the team as their team leader. So we called that person up 2 weeks after the training to follow up with them and, see if they'd gotten started recruiting people, how far along they were, what kind of technical assistance could we offer them to get this going in their community. We asked if we know it's important to get tribal support when you want to do anything in your community because, all these people that came to the training, they already have jobs in their community. Everybody's already busy. So how are they going to take the time to do this extra thing, which takes a lot of time? There were 5 weekly, or they were 5 monthly meetings for the Strong in Body and Spirit. But, recruiting people is difficult. Everybody's got to, you have to find a place to have it. You're going to make sure people remember to come to the meetings. Do you need snacks? All this stuff. Do you need to, transport people there? And had they, within those 2 weeks, scheduled their first Strong in Body and Spirit meeting. And then at 12 months after their training, we called them back again to find out, what their facilitators and barriers had been to implementation, and if they had actually implemented the program. So we found out at 12 months that 59% of the teams met to plan their implementation. Although at the training, we went through the who, what, when, where, how, so that they could plan everything they needed to do at the training. So when they got back to their community, they could hit the ground running. Everybody had their roles already assigned, and they knew what to do. And they developed their recruitment flyer and all that stuff at the training. But when you get back to the community, other things happen. So 46% of the people we had trained had sought tribal support. 56 had begun recruiting participants by 12 months. And then 41% had scheduled their first intervention meeting. Well, that was at 2 weeks post-training.
Hi, Annie.
Yeah.
Was there some sort of incentive to these groups, or you just kind of said, here's the program and...
Yes, yeah. And the incentive is a culturally tailored program for American Indians that produced high participant satisfaction. And back in the 90s, early 90s, that's kind of when diabetes, there was a lot of awareness then just starting around diabetes in Native communities. Before the 1940s, American Indians didn't really have type 2 diabetes because they were lean. They weren't eating fast food that's so readily available now. They didn't have a lot of sedentary jobs. So they didn't have a lot of diabetes then. And it wasn't until after World War II when things started becoming more urbanized in and around Native communities. People started moving to urban centers to get jobs. So now more than 70% of American Indians live in urban areas because of jobs and educational opportunities and things like that. So diabetes wasn't a problem. And some communities, so in the Southwest, Navajo is a large tribal nation. They didn't have any words in their language for diabetes or pancreas or anything like that. But they're largely sheep herders, and so they knew sheep anatomy. And so we would use analogies about the sheep's anatomy and show where the pancreas was and talk about what it does. And also what we learned too, in some cultures and in Navajo, if you say something might happen to you and it does, then they might blame you. So you don't want to say, if you don't control your blood sugar, you might have to get an amputation or something. because then if that happens, then they're going to blame you for it. And so you have to learn all these things about people's culture and their beliefs and how to best communicate with them. So that's why I always hire people and train people from the community, because they're really the cultural bridges for me. I mean, I know some stuff, but they know stuff, and that's why you need everybody possible to make something effective.
So can I ask you one
Yeah.
other question? In your development of these interventions, do you take first empirically supported interventions and then work with the community to change them so they're culturally appropriate, or do you are you part of the development of the intervention, or do you do both, I guess, in terms of developing the interventions?
So it's not always an intervention. So for the diabetes self-management, it wasn't an intervention that we adapted, but it was integrating the clinical guidelines. So American Diabetes Association, using that, the T0, T1 research, comes up with these clinical guidelines every year. So they're clinical guidelines developed for clinicians to use in their practice when treating people with diabetes. So like the goal for A1C is less than 7. Here's all the medication. So have you ever seen clinical guidelines? They talk about, here's what the physical activity goal should be. Here's what the dietary goals should be, or nutrition goals. And like there's a blood pressure goal. And so we took those clinical guidelines and integrated them into a curriculum that was meant for a lay person. And it's written in a conversational tone. So, and there are stories integrated, and I'll tell you more about that. But we integrate stories because everybody, humans had oral histories before we started writing things down. And tribal communities and indigenous communities still have that oral history. Like in Hawaii, they say, let's sit down and talk story. And so you're just sharing information, but that's how we transmit knowledge. That's how we've learned in the past, not through books and things. It was through stories that, your elders would tell you. So we integrate stories. So it's taking those clinical guidelines, but then kind of translating them into a way that people can better relate to them and understand them for themselves. So a goal of mine too is to help people become better consumers of healthcare, and to know what they should be getting and when they should be getting it, and how to ask for it if you're not getting it from your provider. Because everybody's busy, and they might just want to get you in and get you out, which they do. And I want people to be prepared when they go to their doctor's visit, and be prepared and confident in asking for what they want and what they need, and asking questions that they might have. So that's what we tried to do with Partners in Care, which is what we called it after this, after Strong in Body and Spirit, was integrate those guidelines into something that makes sense to the layperson. So at the 12-month post-training phone call, we learned that 67% of the teams that had attended the training had implemented Strong in Body and Spirit. And then, the people that they reached ranged from like 4 to 350. It just depends on how big the tribe was and how many times they'd implemented it. So this was like kind of our first foray into dissemination and implementation research. And it wasn't even called that back then. That's kind of a new term for what they're calling for dissemination and implementation research. So we also found out, asking, what are the facilitators to implementation? What helped you implement this in your community? Well, participant satisfaction was really high. People liked the program. They liked the story. So in this curriculum, the story is called Through the Eyes of the Eagle. And our community health worker that worked with us on developing this had a dream. And it was about an eagle flying over the land and seeing changes in Native communities. People are eating more high-fat, high-sugar foods. People aren't walking around as much, and they're getting this thing called diabetes. And as I said, diabetes was kind of new back then. And there were a lot of misconceptions and myths about diabetes. People thought it was contagious, which, if you think about it, it kind of is, because if you have a family history, you're at risk. But they thought it was contagious. They thought it was a death sentence. They didn't want to be seen like walking or exercising in their community because somebody might think they have diabetes. They didn't want to be seen holding a diet soda because somebody might think you have diabetes. So it was really hard, at first to get people interested in education and admitting that they even had diabetes and come to these classes. So we learned a lot at that time. Facilitators also included team commitment or teamwork, some support of the administrator or tribe, and then positive outcomes for the participants. So, people will report feeling better, their A1C improves. But the team commitment and teamwork thing, we learned that, you ask people to send teams to a training, but they might be a group of people but a lot of them didn't function as a team back in their community. They might not even know each other until they get to the training. So to ask them to go back and work as a team in their community when they've never been a team or they don't even know each other until then, that was a lesson learned. And because a lot of times, and then they had to identify one person in their team as the team leader. And most of the time, if that person left, like nobody took over being the team leader. And so you have to think about all the possible things that might happen. And now we know, if I had to do this again, I would say, choose people that, work together or are near each other in the community so that they can get together and do this program. And a lot of people, like I said, they already have jobs in their community. Everybody's busy. So there was no time. These were some of the barriers or challenges to implementing the program. They had competing demands. There's staff shortage and staff turnover. So in Native communities, you see a lot of turnover at all levels. So that's always a challenge too. So the team-related things, as I mentioned, all the trainees left their jobs. Everybody you trained is gone now, so then what? They didn't train enough people, they found out, or the wrong people were trained. There was a lack of teamwork, and the trainees weren't comfortable teaching, although we did give them opportunities at the training to practice teaching each other in their group. Or like I said, the team leader left. So just quickly, in my my master's thesis, I did the evaluation for the train the trainer that we did, and that's when I got really interested in like organizational theory, and trying to identify what motivates individuals and organizations to adopt and implement programs. And so this was a proposed theory that integrated these cognitive and social processes that we found that affected implementation, as well as some other things, that they've thought about when they developed this model in organizational theory. But as we know, there's a lot of stuff. So all the theories have a lot of, try to include everything, because then if you don't, then people are saying, well, what about this? Why didn't you include this? But then again, you have to be parsimonious in what you choose to intervene on or what you include in models and things like that, because you can't put everything in there. So just wanted to talk about, kind of my passion is figuring out how to motivate people to do what I think they should do. And, so moving, from or between intervention research and the D&I dissemination and implementation research was really kind of natural, because they both involve behavior change. So the next two slides they're really a simplification of the goals of behavior change at the individual level. And then on the following slide, it's about community or organizational level change. So many of the strategies we use in intervention research and to disseminate and promote adoption of programs, drugs, treatments, are kind of marketing strategies. And I often wish I knew more about marketing, because a lot of time, I mean, you think about all the stuff that they advertised on TV and the radio and social media and things like that, and like they really know how to get us to buy stuff that we probably shouldn't be buying or eating. So we use strategies to, sell our programs to potential users. For example, in research, we have to sell or convince individuals to participate in our studies. So that's why you have to figure out, what motivates people. And I have 2 studies going on now with American Indian men to try to get them to lose weight because men don't come to interventions, especially weight loss programs, where you have a bunch of women sitting around talking about weight loss and how hard it is to lose weight and stuff like that. So we felt, it was important to make a men-specific program and figure out, what would get them to come to classes and what would they want to do at these classes and like what kinds of incentives would get them there. So we have to find out what motivates people. Then, if people like the program, then we can hope they'll continue to use it or adopt it and then tell others about it. And then hopefully it becomes, routine or integrated into their lifestyles. Same with community behavior. The goals of individual level behavior are similar to that of community or organizational level behavior change. So as with individuals, if a community or organization decides to try our program, we hope they like it and it's beneficial to their clients. But the routinization and the integration depends on the nature and the scope of the intervention. So a lot of times these long-term programs, programs that involve a lot of work and a lot of classes or something like that, or a lot of money, don't last. So we worry about sustained implementation too. So there's, immediate implementation of something, but is it going to be sustained in the long term? And then for public health impact, that's really important, is the sustainability of evidence-based practices and in real world settings. So I've done several iterations of this diabetes self-management program. So the first one, the Partners in Care, so Strong Body and Spirit and Partners in Care then became just Partners in Care. But Strong in Body and Spirit was the one with just diet and exercise. Then we created another one based on people's feedback about what else they wanted to know about. They wanted to know about medications for diabetes, the side effects, what are the complications from diabetes? How can I avoid those? How to better communicate with their providers and getting social support for their behaviors. Because eating and exercise, you need a lot of support sometimes to make those happen regularly. So the Partners in Care, the self-management, the more clinically focused one, was 1997 to 99. Then I went to Michigan, and they had a project in Detroit with African Americans and Latinos, and the REACH projects, those were CDC funded programs across the country. It's racial and ethnic approaches to community health. And so they were working with African Americans and Latinos who had diabetes in Detroit. And they had already hired and trained 5 Latino and 5 African American community health workers, and they called them family health advocates. And they'd already done focus groups, and they were interested in diabetes, and so I convinced them to let me adapt the Partners in Care for that project because their plan kind of fell through. And I was a new grad student, and so like my first year I spent going through the focus group data and adapting the curricular materials, because self-management is the same for everybody, but the way that you talk about it, the way you convey messages and motivate people will be different. So we had to figure out how to best do that. And then I went to Hawaii. We did Partners in Care there, adapted for Native Hawaiians and Pacific Islanders. and in 2010 to 2012, and integrated it into their usual. So what hardly ever happens to me, which has never happened before Hawaii, after I left there, I was there for 5 years, and then I moved to Seattle. They got funding for dissemination. And so they had adapted the diabetes prevention program, was a weight loss program that NIH did a big trial. But they adapted it for Native Hawaiians and Pacific Islanders. So under this one funding mechanism, we had the weight loss program, which they called Piliohana, and then we had the Partners in Care, which is the diabetes self-management. And we had trained community people to implement both of these in their communities. And so after the funding for the research project was over, they got funding to disseminate this to other Native Hawaiian serving organizations in Hawaii. And so they went to organizations and asked, did you want to learn how to implement these programs? And so they trained people how to implement the Partners in Care, the people that I trained. And now 3 clinics in Hawaii are using that curriculum as their standard diabetes self-management education. And they're getting reimbursed for it, because through the American Diabetes Association, there are clinics and organizations that can apply for diabetes. They call it diabetes recognition, which means then that you can, if you get this recognition and meet all this criteria, you can get reimbursed through Medicare and Medicaid for providing diabetes education to individuals with diabetes. So they're still using it. 3 clinics. I was just floored that, because this hardly ever happens. And and after research is over, unless you're getting reimbursed to continue it, or maybe it builds on some other project that you get funded, a lot of times things don't continue. They're not sustainable. So this was just amazing that this happened. I was just so happy. And I went there for a conference a couple years ago, and this one team from this clinic in Hawaii brought their team that was implementing the program, and then they brought one of the patients who had attended the classes. And he was telling how great it was, and he was so appreciative, and his wife is helping him now and everything, manages diabetes, and he got like real choked up, and then I got choked up. I'm like, oh my God. So it's really awesome to see that something that you've worked on really helps people. So that was awesome. And what they did, which was fantastic, and a lot of times, you need to have a champion in the community or in the organization to really move things forward. Well, the physician who was in charge of residency training really liked the curriculum, and so he makes all his residents attend some of the classes with participants to hear what they're going through, and to better understand from the patient's point of view what's happening, what are their challenges, what do they need help with. So he really pushed for them to have this, and then the nurse educators were really happy with it too. So that was awesome. And then last November, I got to go to Saipan and do a train the trainer there. So they brought their public health department, brought in people from some of the islands around there, Guam and some other places. And I did a train the trainer for their community health workers and nurses and stuff. So that was really cool. You never know what's going to happen. Some of the current stuff that we have going on, or forthcoming translational or D&I research. As I said, I've adapted the diabetes prevention program educational materials, which is diet and exercise, for American Indian men. One site is Colville, and Dr. Cook was so gracious to get Fitbits to give the men, to try to get them motivated to come to the program and enroll. And it's a more objective way to track physical activity. And then I have another bigger trial going on in 3 different sites with American Indian men, same outcomes, weight loss. And then we have a living donor kidney transplantation project. So we know that most people on dialysis is because of diabetes and have lost kidney function. And a lot of American Indians and Pacific Islanders who are on dialysis don't get transplanted as frequently or as soon as white folks. And there are very, very few American Indian and Pacific Islander living donors. So, if you're on dialysis, the sooner, if you're eligible for a transplant, the sooner you can get transplanted, the better quality of life and the longer your life will probably be. So we had an educational program for dialysis patients and their family and friends to learn about the kidney transplantation and getting on the kidney transplant waiting list, because it's a huge medical evaluation process that you have to go through, and it can take a year to get through the medical evaluation process. So lots and lots of issues just getting that done, even like among educated people. So a brother-in-law of mine had a kidney transplant and got a kidney from another brother-in-law of mine. And they have an educated family, but it took at least a year to get through everything. And you really have to push to get the appointments, because the appointments aren't all in one place, and you have to have a lot of stuff done, and both parties have to be in really good shape to get the surgery. So we learned a lot from that study too, all the issues people face in getting transplanted. We did deliberative discussions with American Indians across the country in 7 different sites about biobanking. So there's a big initiative funded by National Institutes of Health about precision medicine. And so precision medicine is to try to identify better and more effective therapies based on one's genes, lifestyle, and so they need like millions and millions of biospecimens from a variety of people to be able to do these studies. And it used to cost, a ton of money to map the human genome, but now it's quick and much less expensive. So they're moving into this precision medicine initiative, and they want to recruit at least 1 million Americans over the next 3 to 4 years, I think, across the country from diverse settings with and without diseases and conditions. And they're going to bank those specimens, I don't know where, but they'll bank those specimens, and then the specimens will be available for researchers to kind of like check out and do whatever research they're interested in. So, it'll be interesting, but it can take many, many years before you see any benefit from that kind of research. And for some American Indians and other people, they don't want to give up anything because they believe you could do something bad with it, or it has been used to negatively stereotype a community based on genetic studies and things like that. So we wanted to find out under what circumstances would American Indians donate biospecimens for research. And let's see. So the Partners in Care, I'd still like to do here in Washington with Pacific Islanders. So Washington has the 3rd largest population of Native Hawaiians and Pacific Islanders after Hawaii and California. And when I got here, I looked through the literature and nobody's doing anything with them. And they have all the same issues that American Indians have and African Americans. And so I've started kind of a community academic partnership to build collaborations within the Pacific Islander community in Washington, mostly Western Washington, but a lot of Samoan people and a lot of Native Hawaiians, but Hawaiians are kind of spread out in Washington and harder to get to. And then they don't really come to the mainland to hang out with each other. Because we had a hula study. My colleague in Hawaii got a grant because they had a pilot study to do hula, which is a Native Hawaiian traditional dance, to improve blood pressure. And they showed that it improved blood pressure in a pilot study they did there. And then they got a bigger grant, and I told him, I convinced him to include Seattle as a site. And I only had to recruit like 50 Native Hawaiians, but it was a year-long program too. And like 2 weekly hula classes. And there are a lot of hula halaus, which is a hula school, and then the kumuhulas are the hula teachers. And so there are a lot of those in Western Washington. But, we met with them and they said that most of their students aren't Hawaiian. And then when we tried to recruit for this study, like I could get no Hawaiians that wanted to join. Everybody else was interested, but no Hawaiian, and they had to be Hawaiian for this grant. So I just gave them the money, and it wasn't enough money really to do it either. So they're just doing it in Hawaii. But it's hard doing stuff in Hawaii because grant reviewers think, oh, you can do it in Hawaii, but then it's not going to be generalizable to the rest of the world. And, with Hawaiians being a large portion of the population, sometimes it can be difficult to get funding to do stuff in Hawaii. And they think because Hawaii is so sunny and nice and stuff, everybody's always exercising and swimming, and they're not. They're eating. How many of you know about system dynamics? Have you ever, or simulation, modeling, stuff like that? So this is super exciting for me, and I hope it gets funded sometime. It's been a long road. But a couple years ago, I got to go to a week-long system dynamics training. And they had agent-based modeling, system dynamics, and then social network analysis. But I went to the system dynamics one. And there are kind of two parts to system dynamics. There's a group model building, which is more of a qualitative process you use with stakeholders to have people brainstorm to come up with, the model of how they think something works. So, if I asked you, what do you think leads to gun violence, and how can we stop gun violence? Then, people would start talking about what they think happens or what leads to what, and you draw that in this map, and have feedback loops and things like that. And then there's the actual modeling of the simulation part. And then you have to use these computer programs, which I'm not an expert in, and I learned that I would never be an expert in going to a week-long class. But you hire the people that are, and then you choose the things in your model, and again, it has to be a parsimonious model, but to simulate then in a computer program, where are the leverage points? So where in this can you intervene to then maybe lead to implementation of this program? So you put in all these things that, and then, so simulations, take into account feedback loops. So think about an airplane simulator. So it took a long time to come up with a simulation and for, potential pilots to use to see what happens, if you run out of gas, like what's gonna happen? I mean, we know it's gonna happen, but, if something happens in your plane, how does it affect everything else in the system? And so for these leverage points, we know that, say policies are put in place, but that doesn't mean that they're actually enforced. So what might be a better place to intervene, like say in an organization, to actually implement or to lead to some outcome? And so that's what the simulation modeling can do. And so this National Diabetes Prevention Program was the DPP before. That was funded by the NIDDK, and they did this huge study just to see if losing weight through diet and exercise can prevent diabetes or delay onset of diabetes. And they did this huge trial across the country, and they found, yes, it can, even though they'd already done the study in China and in Finland. The US always has to do their own study. And so now this program is being offered, it's funded, the CDC has funded Emory University in Atlanta offer this Train the Trainer program. It's a day-long or 2-day training, $700 or something. Anybody can go to this training and learn how to implement this educational curriculum about diet and exercise. Well, now they've trained over 2,000 people across the country how to implement this curriculum. But nobody's done an evaluation to see whether anybody's actually using it, how many times they might have implemented it, nobody knows. But, and the important thing is, Medicare is going to reimburse this coming soon. They're writing the rules now. But, if it's not effective, or it's only effective in some certain types of organizations, then it's a huge waste of time and money for people to come from organizations like churches or something. They're never going to get reimbursed because they don't have the infrastructure to get reimbursed, to bill. And so I'm really interested to find out, where, what kinds of organizations are more successful at implementing this. What can we do to improve or increase implementation in those organizations where it's not being implemented? And what are the facilitators and challenges to implementation? Because I know it's hard to implement programs in organizations or communities. It's a lot of manpower, woman power, and time and money. So we're writing a grant to do that. And using system dynamics then, and those group model building sessions with people that have been trained to figure out, what are the facilitators and barriers, and what are the leverage points in different types of organizations where you could intervene that might improve implementation. Because they're looking, this is like the be all end all to CDC of weight loss programs right now, that they want to get reimbursed, and a lot of people don't think it's working, and on a population basis, and they've put a lot of money into it. So